This is a continuation from our prior episode. This is the Change Physician, episode 218. Kevin, would you like to transition to the next book?
Yeah, because I mean, there's a wealth of topic here, so we can move into your second book, which is
Hippocrasy.
Can you pronounce it Hippocrasy or Hippocrasy? I couldn't.
It could be either.
Because I thought it was like Hippocrasy, and I'm like, is it because we're all like crazy and not following the Hippocratic Oath, or
yeah? So it's just a mashup of Hippocrates and Hippocrasy. So it's spelled, HIPPOCRASY. So it's the subtitle is How Doctors Are Betraying Their Oath.
So go ahead, Kevin.
I was gonna say, and how are doctors betraying their oath?
Yeah. Well, what I wanted to do after I'd written the book on surgery was to write a book more generally about modern medicine. And that's when I enlisted who was by then a close colleague and co-investigator and researcher, Rachelle Buchbinder, because she was an academic and clinician, very similar to me, but in the medical side, whereas I was on the surgical side. And I thought if we had the two of us, we could probably cover a lot of ground. So the idea of the book was to point out the problems with modern medicine. Again, over-treatment, over-diagnosis, medicalization of normal, a lack of science, this reliance on observation over experimentation. So the message is simple, but we're talking more generally, and we talk about system issues, and we actually argue that the healthcare system that we work under is not fit for purpose. It actually doesn't work to improve health. It works to promote the turnover of healthcare activities. And those two often don't lead, one doesn't lead to the other. So that's the premise for the book. And we thought, well, how are we going to frame this? And we looked at the Hippocratic Oath as maybe something we could turn to. And it was a light bulb moment, because when we looked at the Hippocratic Oath, the two things we found was, first of all, it was a very good oath. I didn't really know what it was, and we don't take the Hippocratic Oath in Australia. I don't know whether medical schools still do in the US, but we don't. But we know about it because we watch TV. But we looked at it and we thought, this is pretty cool. Like, this is pretty hard to argue with, these things, and so we thought, oh, it's a really good oath. We like it. And then as we were reading each of the 9 pledges, we were kind of like, this is exactly what we're not doing. I mean, this is describing pledge by pledge everything that's wrong. And so we just took each pledge and made it a chapter of the book. And we added one, which was first do no harm, which is not part of the Hippocratic Oath, but it's commonly attributed to Hippocrates. So we just threw that in as a 10th chapter. And so first do no harm, first chapter, we highlight the harms of modern medicine, because they're completely underestimated. I mean, it's been reported that around a third of healthcare is ineffective, and another 10% of what we do in healthcare activity is actually harmful. And between 150 to 400,000 people in the US, it's been estimated, will die from medical interventions each year. But people just ignore these numbers. I mean, these are massive numbers of harm, and it's written off as the price we pay for all the good that modern medicine does. And so we put this in perspective, because modern medicine isn't as good as we think it is, and it's a lot more harmful than we think it is. And so we've got some great examples of where people kind of get that wrong. And there's been studies looking at physicians and reviewing all the literature, where the estimate of benefit and the estimate of harm given by physicians is put up against the actual evidence. And it's fairly consistent that physicians overestimate the benefit and underestimate the harms of what they do. their assessment of the complication rate of an operation is far below what the true complication rate is. And we've done research looking at the satisfaction of patients after surgical procedures, asking them how satisfied they are. And then we go and ask their surgeons how satisfied they are with that patient's outcome. And there's always a discrepancy. And this is a problem, because when a patient goes to see a surgeon and the surgeon says, yeah, on the balance of things, I'm looking at your knee or whatever and your x-rays, and I think I would recommend a knee replacement for you, as an example. That surgeon is basing that recommendation on their own perception of how likely it is to be successful and how likely it is to be harmful. But that perception is consistently distorted. They're making that recommendation on an assessment that is wrong, that is an overestimate of the benefit and underestimate of the harms. And then I can't remember all the pledges, but the other pledges of the oath say things like, I shall respect the science. So we use that to say, there's not enough science in medicine, there's too much reliance on observation. There's another great pledge which says, I must treat a patient, not a fever chart. And we use that to go into the fact that often there's this obsession in medicine with treating the numbers, not the patient. Or in orthopedics, we say treating the x-ray, not the patient. And so there's some great examples in that. I shall prevent disease wherever I can. I shall not play God. There's all these sort of great pledges that you can use to spin off into what's wrong with medicine.
Oh, absolutely. I'm curious, the birth and death thing, it's discussed in that chapter. What is that focused on?
Yeah, there's a pledge on something to do with birth and death, but or life, and we use that to look at the medicalization of birth, the interventions that doctors do during delivery or cesarean sections and immediately after, and how it's. I mean, you couldn't get a more natural process probably than birth and death. But they've just become medicalized, and death in particular, and this idea of a good death, as opposed to just extracting every last drop of life you can out of people, regardless of the quality, and how people used to die at home, but now most people die in hospital, and in fact they die in intensive care after having futile treatments for weeks on end, just to try and extend their life a little more, because we're just not sure, and we just better make sure. And there's a great quote we used to open that chapter, and I've forgotten the name of the physician, so apologies to him, who made it. And he said, in Scotland, where I grew up, death was imminent. In Canada, where I trained, death was inevitable. But in California, where I now live, death is optional. Death is seen as optional, and I always thought that was sort of a good quote. But it is, death is this thing that must be fought on all grounds, and often to the detriment of the patient and the family and the health system.
Yeah.
I'm wondering, in all your talks and being involved in surgical societies, as well as I know you've done a lot of presentations, have you found, have you seen with the discussions that you've had, have you had any success with changing people's opinions? And if so, how did you do that? Because a lot of this is about belief change, and beliefs are extraordinarily difficult to change in another individual. In fact, you can't reach in there and turn off their belief system. But I'm wondering if you've had any success because you have abundance of data on your side, and they have, unfortunately, abundance of anecdotes on theirs. And when we're looking at anecdote versus evidence, at least in America, anecdote trumps evidence almost every time, at least when I'm talking to people, because you say, well, this evidence shows this, and they go, well, I don't care what the evidence says. My patient walked in the door and he says it works, so it works.
Yeah, and again, I don't want to pick on Americans, but that is a very common attitude over there. I mean, I've worked over there for a year, and I have lots of trainees and surgeons that work under me. I mean, it's very common to go to the US or other countries for a year after our training. And we see this, but there certainly has been change. So things are much better now than they were 20 years ago in surgery, but particularly in orthopedics. So things have changed, but it's difficult to determine exactly the cause for that, and how much any individual has been responsible for that. But there's been some interesting research looking into practice change amongst orthopedic surgeons. And what I usually say in my lectures is that the science will usually win out in the end, but the process by which change occurs is a social phenomenon, because the surgeons change practice because they see other people around them change their practice, and they think, oh, hang on a minute, maybe I need to be doing that. That's how they change their practice. They change their practice by going to meetings, by talking to people, by discussing it, and it's what I say, it's by line of sight. So practice change occurs by communication between individual surgeons, not by the reporting of a major study in the New England Journal of Medicine. Unfortunately, I would love to see practice change the day after the publication comes out, but it doesn't. And the process by which it does is social. And then so somebody has to lead the way. And so sometimes there's a thought leader or there's a debate or something, and then these things are aired. Then that causes some people to question it, and then some highly respected, perhaps high volume surgeons change their practice, and then other people follow. And sometimes it's a generational thing. And I would say, in my experience, that the people who just do not listen to the evidence about knee arthroscopy, for example, are surgeons who are in their 60s who have been doing this procedure for 30 years and do it all day, every day. And there's no room for them to have doubt enter that. That's been their life. Whereas younger surgeons who come through without having that personal observational evidence to sway them, and perhaps being more questioning in nature and having this evidence thrown at them during their training, are much more open to this. And so there's a big difference between younger surgeons and older surgeons. And so there's this generational change, so that the surgeons that are doing too many of this procedure are gradually retiring, and younger surgeons are gradually replacing them. So and that's about the slowest way of changing practice you can get. But unfortunately, that's part of practice change.
Yeah. I almost feel like there's still a challenge with, for them to just wipe out a procedure that sustains their roof over their head and their family, if that's their specialty. There always seems like there's like a conflict here on
they don't want to hear it. There's no room or capacity for them to see the procedure that they've staked their whole career on and that they earn their money on as being somehow ineffective.
Yeah, that's too threatening. Obviously,
yeah,
sense of identity or money.
Or we'll see in the pain world, because I'm interventionally trained, is the argument becomes, well, if it's placebo, but they still say that it gets better, so we should be able to do this anyway. I mean, that literally was an argument.
I get that argument in surgery. I can't believe it. But I've had surgeons sit with me over dinner and just say, I remember when the second placebo knee surgery study came out, and it was big news and everybody knew about it. And I was sitting next to a surgeon. He said, I think it's great. I'm going to do more arthroscopies than ever. And I said, okay, you've got my attention. Why? And he said, because most of the patients in that study got better, regardless of what they had. So if it's a placebo effect, then that's fine. I'll just use the placebo effect and I'll keep doing the procedure. And I had to explain to him that he's misrepresenting it. And there's a problem with using the placebo effect. The first problem is that it's not a placebo effect. It's probably what would have happened to the patient if you'd have done nothing. That's the first problem. The second problem is that you're putting patients at risk.
Mhm.
and inflicting cost to the patient and the system,
Mhm.
and using up resources that could be used for more effective surgery. The third problem is that as soon as you say, well, it's a placebo, but I don't care, you have removed what I see as the main partition or barrier between scientific or mainstream medicine and alternatives to medicine. Because the difference is supposed to be this scientific basis. And so we criticize non-medical practitioners, homeopaths or things like that. We criticize them by saying, well, this is rubbish because it's just a placebo, and you haven't done proper scientific studies to compare what you're doing to a placebo. That's the difference between medicine and non-medicine. So as soon as medicine starts doing that, there's a problem.
Mhm.
And that's an excellent point, because we don't, right? And we do that. We poo-poo the alternative care, and they do some
but we
crazy
don't apply
stuff.
the same. We assume
Yeah.
that everything we do is scientific, and we assume that everything that other people do isn't. But we don't apply the same benchmark to our own interventions.
Yep. Well, yeah, I could go on a different tangent there. We won't do that. Out of curiosity for the people listening, Rachelle and yourself, can you describe, like, location wise, like which state like you guys are in, and just like the system you're playing with there medically?
Yeah, so we're both based in Australia, and Australia has I don't even know what the population of Australia is now, but it's probably over 25 million or so. So it's, you can put that on a scale. It's actually a fairly large population compared to a lot of countries, but it's probably a large state or something in the US equivalent. But in Australia, most of the population is on the eastern seaboard, and the by far the two largest cities in Australia are Sydney and Melbourne, which are fairly close in population of about 5 million or so, 5 or 6 million people. So these are large cities, and they're by far the two largest cities, and they're in the two most populous states, which is New South Wales and Victoria. So I'm based in Sydney, and Rachelle's based in Melbourne.
Okay.
And so for the top universities, the biggest hospitals, the biggest commercial centres and stuff like that are in Sydney and Melbourne.
Okay. And for those not familiar with the Australian medical system, how would you compare it to like the US?
It's what we call a two-tiered system in Australia. And so we have universal healthcare like every industrialized country in the world, except America, and which is just
Mind-boggling.
crazy, mind-boggling. But we also have private health insurance, and so roughly half of the population voluntarily takes out private health insurance. It's not employer-based insurance. It's a person takes out medical insurance just like they would take out car insurance. And there's actually some tax incentives to do that, to take the pressure off the public system a little bit. And so that's why about half the population do it. The advantages of having a private health insurance is that if you want to have a knee replacement done or elective surgery or something, you can get it done in a private hospital without having to wait with the surgeon of your choice doing the procedure. Whereas if you go under the universal healthcare, it's actually called Medicare, but it just happens to be called Medicare. And I know that there's a Medicare in the US. Medicare in the US is for people aged over whatever, but Medicare in Australia is for everybody. And in fact, it's probably not a whole lot different. And I think if you had Medicare in the US and you just removed the age requirement for it, you would have a system that's probably not a whole lot different to a universal healthcare system. So I think in the US you have a universal healthcare system. You're just only applying it to people aged over 65, is it? I think.
65.
Yes.
Yeah.
Yeah.
So, but if you want a knee replacement, you might have to wait a year to get it done, or 9 months, depending on where you are.
Which may not be a bad thing,
Which
apparently.
may not be bad.
No, it may not be. And yeah, I get it. I could go on all day about knee replacements and the alternatives, and how a lot of people could probably avoid knee replacement surgery by having non-operative interventions.
Mhm.
There was a recent study actually that got published by colleagues in Melbourne, and they looked at randomizing patients who were on the waiting list for knee replacement. So these are patients who had arthritis of the knee, had been deemed worthy of a knee replacement, and were put on the waiting list to have a knee replacement. And we can sometimes make use of this fact that patients have to wait a little while for their surgery to do studies on them.
Mhm.
And so they did a study, and they looked, because a lot of patients who have knee replacement are obese, because there's an association between obesity and knee arthritis. And so they took the patients who were very obese and randomized them to having gastric surgery, weight loss reduction surgery, compared to just usual care. And they found, of course, that the people who had the surgery lost weight. And the aim of the study was to see whether that affected their complications and the outcome of the operation, so that when they had the knee replacement, would they do better if they'd had the weight reduction procedure first. But what they found was that more than a quarter of the people who had the surgery and lost weight didn't need to have a knee replacement. So they just went off the waiting list completely. And that was a very significant finding. But as surgeons, we tend not to have that discussion. It's kind of like, well, your knee's worn out, so we'll replace it.
That I think is because so much of this, we're kind of confronting these biases of, well, it just seems to make sense until you start cutting through it a little bit, and then it doesn't make sense at all. But for joints, you're like, well, the joints wore out, it would seem to make sense, but that doesn't seem to be.
Yeah, it's like, and I use this a lot in the first book, and a little bit in the second book, is this it's thinking fast and thinking slow. People say things and kind of, oh, that makes sense. But then you start to think about it for a while and you go, well, it doesn't make sense. And surgeons often say to me with knee arthroscopy, they say, well, the patients come to us and they've failed non-operative treatment, so we operate on them. And it's kind of like, oh, well, that makes sense. If they failed non-operative treatment, we give them operative treatment. And it's kind of like, but hang on a minute, the operation doesn't work. So the failure of one type of treatment doesn't make the other type of treatment suddenly become effective if it's not.
Yeah. And the strategies and effectiveness and all those things, if they were even appropriate or done, over the right period of time, that's another question mark.
Yeah. And I guess it goes to what we say in the book as well, is that a lot of what goes wrong is well-intentioned. So doctors aren't out there trying to harm people. I mean, this 10% harm we talk about isn't deliberate. I mean, it's all well-intentioned, and screening is a classic example of that. It's very difficult to see, even for doctors or lay people, the harm that could come from having a test or some kind of screening test. How could that possibly be harmful? Because surely if we do a test on you, we will know more than we know now, right? So how can more knowledge be harmful? That's a really difficult concept. That sounds like it's a good thing to do a screening test. And but there's so many examples of where it goes terribly wrong. Getting back to back pain, well, we'll just do an MRI and just see what's going on. But if you do an MRI on anyone aged over 40, you will find something. I've been in practice for 30 years. I have never seen an MRI scan report that says this looks fine, everything is okay here, nothing to see. There's always like 2 pages of little things that the MRI picks up. And so then it becomes, wow, gee, I wonder if that's causing the pain. So now maybe we might need to operate. And so you can see where it all goes wrong by doing a test. And the other large scale example we use is from South Korea, where I think it was in the 90s or early 2000s, where they thought it was a good idea to screen for cancers. And so they had a list of cancers that they were going to start screening for, because they, it sounds good that if you're going to pick it up early, you will save lives. And one of the cancers that wasn't actually on the original list, but the doctors thought was a good idea, was thyroid cancer. And what people didn't understand is that a lot of people have thyroid cancer, but never know about it. And if you look at the thyroid of people who are aged 80, you will often see these low-grade cancers, papillary cancers of the thyroid, which are sitting in so many people's thyroids, not killing them. But so they started scanning everybody to look at their thyroid, and they found these lumps. They found these low-grade cancers. And so once they found them, they're kind of like, well, we need to take them out because you've got cancer of the thyroid. We're not going to leave it sitting there now that we've found it. And so they had this mass screening program at great cost, and thousands upon thousands of people were diagnosed with thyroid cancer. And so it became, in South Korea, thyroid cancer became the most common cancer diagnosed. Now it's not even close anywhere else in the world, where it's like lung cancer, breast cancer, prostate cancer, colon cancer. These are the common ones. But all of a sudden, thyroid cancer became the most common cancer. And thousands or tens of thousands of people were having their thyroids taken out. Now, that's a problem, because if you have your thyroid taken out, you're on lifetime hormone replacement therapy. Not uncommonly, when you take the thyroid out, you accidentally take out the parathyroid, which is a completely separate organ that is produces a different type of parathyroid hormone, which is a different type of hormone. And that can cause terrible metabolic problems. And then you're on lifetime therapy and monitoring for that as well. And when you take out the thyroid, you can injure the nerve to the vocal cords, and you can get bleeding. And so there were deaths, people losing their voice, people on lifetime replacement therapy, incredible harms from the tens of thousands of people that had their thyroids taken out because of the screening program all over the country. And the rate of death from thyroid cancer across this whole period did not change. So they probably didn't save any lives and caused untold harm and incredible cost to the system. So they had this system which was not fit for purpose. They had a system that was driving, screening, replacement, treating the complications. This huge health system was not producing health. It was harming people. But it was increasing healthcare turnover, or turnover of healthcare activity.
Yeah.
Well,
Yeah.
I want to be really respectful of your time. So there's two things I'd like to kind of catch up on. And number one is, you commented about thinking in physicians, and this is just a comment on that, because this is so important. If physicians listening to this, is because we have this inherent responsibility. And this idea that your patients can come in and be fully informed and make good decisions is in many ways nonsense, because they don't have the domain specific knowledge that we have. So we need to be making those better informed decisions so we actually appreciate this stuff. Because I mean, there's all this data. We have this data in the United States on these decision aids and how they're supposed to help, and they don't. But from the last standpoint, though, is until the system changes, what do you recommend for your friends and family who are perhaps not medical, when they're entering or touching their toes into the medical system? What questions do you suggest that they ask, and or what are their considerations that they should have when they're kind of entering the system?
Yeah, so these are really good questions. We actually answer this in the last chapter of the book. But the two things that I often recommend to people is first of all, ask the question, what is the probability of me getting better with this procedure that you recommended compared to if we don't do it? And that sounds like a really like kindergarten grade question, but it's the core of the problem. And often doctors get thrown when you ask them that. and you say, well, you're recommending I have my prostate removed. So what's the probability of me dying later or earlier or whatever if I don't have it removed? And for that particular patient, there might not be a difference. They're just recommending it because there's a cancer there and they think that it might help. But when they look at the evidence, maybe it's not there for that particular patient. And the other thing I say is to get a second opinion and a third opinion, because opinions vary a lot, and ask around and find out, somebody else that you might be able to get a different opinion from, or get a third opinion. And if they're all saying the same thing, well, I'd feel a bit more comfortable about it. But if you get one surgeon who says, oh yeah, you need a spine fusion because your back is terrible, look at your MRI, and you go and see another surgeon and says there's no evidence that doing the spine, so doing a fusion will help you, then something's wrong. You need to think about this a little bit.
Sure.
Yeah.
If somebody wants to learn about either your research or find your books, Rachelle and you or whatnot, where would you like to send them, or where's your preferred area for them to find your knowledge?
They can probably just Google us and find us. So, on Google Scholar, or go through, I guess, our universities. So it's Monash University for Rachelle, but Rachelle's pretty easy to find on the internet if you just type in Rachelle Buchbinder, because it's not a common name, and she's got a high profile. And for me, it's the University of New South Wales and the University of Sydney that I'm associated with. But it's not hard to find us out there.
Sure. Well, we'll put those in the notes so they know how to spell her name and
yeah.
find you guys.
Because you have 2 books now, so there's a decision right there. If you're a physician and you're interested in learning more of these topics, would you advise them to start with Surgery, the Ultimate Placebo, or with Hippocrasy?
Probably Hippocrasy. Probably start with the second book. Yeah.
Okay. And what about the lay public? Is it the same thing? Would you start with the second one and go there, or would you start with the Surgery?
Either one.
Either one.
They both got great stories in them.
Yeah.
I love it. I'm looking forward to getting more through your second book, and I think I read your first one twice, but it was awesome. Well, thank you again. Did you have any last words, or do you mind if I take us out?
No. Thanks very much for having me.
Absolutely. Well, for those of you that are here watching The Changed Physician, maybe seeing it on Facebook, or don't know what this is all about, you can go to thechangedphysician.com to learn more about Kevin and I, and to hear what our community is all about. And you can feel free to join, whether you're a physician or a physician ally. And until next episode, take care.
Stay well, folks.